This program is brought to you by Emory University.
Today, our speaker is Dr. Mavromatis, who is the director of the cath lab at the Atlanta VA. He's also part of our structural heart team and has been part of some of the large, very prominent clinical trials in CAD over the last few years. So we're very happy that Dr. Mavromatis could give us this lecture every year. Thank you again, Dr. Mavromatis.
Thanks, Kunal. Glad to be here again, and good morning, all you guys who woke up and are listening to this. Thanks for coming. Kunal asked me to speak about the management of stable ischemic heart disease. I use that interchangeably here with stable CAD, although, as you all know, microvascular disease is part of the picture, but basically it's a pretty big topic. So I'm going to be probably the full hour, pretty near, but if you have any questions, please don't hesitate to chime in, and we can always address those, since I think those are probably the most important things. So yeah, management of patients with stable ischemic heart disease, or more specifically, stable coronary disease. Let me get rid of this box here. Basically, the kind of patients I'm talking about this morning are patients who are either asymptomatic or symptomatic with very stable symptoms, angina specifically, that has not been worsening for at least 2 months, and they have epicardial coronary artery stenoses, or they have a history of stenting or bypass of epicardial stenoses. Not talking about the microvascular dysfunction patients here. So we'll focus on the epicardial disease patients. Basically, I want to go over these 5 aspects of stable ischemic heart disease. Firstly, the scope of the problem. Secondly, diagnosis and risk stratification of these patients. Thirdly, medical therapy. It's a big and growing topic. Fourthly, revascularization, specifically in whom and how. And finally, talk a little bit, if we have time, about follow-up of these patients. So the scope of the problem is large in our population in the US. You can see here, women and men, what the prevalence of coronary disease in different age groups is. And overall, basically it's 6.3% of US adults affected, but as you can see, very few people in the less than 40 age group, and a huge minority of patients in the 80 plus age group. But 6.3% of US adults is a big number. 13 million outpatient visits a year for CAD in the medical system, and it's the 3rd leading cause of disability in the US. So very, very important problem. It's called stable, but it really isn't. Over the short period of time, months, things generally don't happen. But if you look at years, things ultimately do happen in terms of events in these patients. And here you can see from the REACH registry of 26,000 patients from the early 2000s that the chance of having a cardiovascular death, MI, or CVA, the most feared problems, is about 14% over 4 years. Not huge, but not insignificant. 14% over 4 years. If you add just hospitalization for unstable angina, non-STEMI, et cetera, you're up to approximately 25% of chance of ending up in the hospital in 4 years. Let's talk about the diagnosis and risk stratification of these patients. I'll start with a question or a case, I guess I should say. 55-year-old postman, history of coronary stent 5 years prior, presents with chest pain, which is atypical for angina. He gets it at both rest and when walking his mail route. He's 6'0", weighs 200 pounds. His blood pressure is 148/80, heart rate of 60, LDL is 80. He's on aspirin, pravastatin, lisinopril, and hydrochlorothiazide. His ECG shows normal sinus rhythm with borderline inferior Q waves. The question is, what's the next best test for this patient? Treadmill with imaging by nuclear, just a pharmacological nuclear, a CCTA, or a cath. If anybody wants to chime in, that'd be great. What would you pick? Well, let's go on before you chime in. Let's go on and talk a little bit about how we approach diagnosing and risk stratifying patients. Basically, it has to do with these three main issues, these three main factors. The patient's symptoms, are they very typical angina, or is it more atypical angina, or is it some other symptom, an anginal equivalent like dyspnea and exertion? Risk factors, what are their risk factors? Prior CAD being, the ultimate risk factor. They have it. But all these risk factors can add up. And finally, baseline tests, you usually have an ECG or sometimes even an echo on a lot of these patients when they present to you. All these things go up to make up the patient's pre-test probability, which is very important in us determining what diagnostic tests we jump to. The other thing that plays a role in our diagnostic test strategy is comorbidities, renal insufficiency, cancer, dementia. All these things play a role in terms of helping us pick our test. And, there's a lot of different tests available, and different tests are more emphasized or have better logistical options in different medical systems. But this is a good diagram showing how I think about testing in patients. You can look in the x-axis, very low to very high probability. The very low probability meaning no tests at all. You may be able to tell them, you may be able to reassure them just based on clinical history and their whole pretest probability in and of itself. Whereas the very high probability patients may need to go straight to cath. But when you're dealing with most patients, the vast majority of patients should be getting some sort of a non-invasive test. And, coronary CTA, I tend to lean towards in people who are younger, do not have known coronary disease, and have a nice heart rhythm for the technical aspects of getting a coronary CTA, whereas patients who have known coronary disease, where CTA is not quite so helpful, maybe, or have impaired renal function where contrast is going to be an issue, or irregular heart rhythm, I lean more towards the functional ischemic tests. So for this gentleman, I don't know if anybody wants to chime in. I unfortunately can't see the participants right now, but I would say I would probably pick an ETT imaging study on this gentleman, because CTA is not so good. He's had a prior coronary stent, making it, the fact that interpreting a stent in and of itself is difficult, but then also calcium in patients with a lot of known coronary disease also makes CTA less specific. So I think in him, an exercise MPI would be most helpful. Here's another patient, 50-year-old security guard, 3 episodes of chest pain walking over the last month. Pain occurs in his left chest. It resolves in 2 to 10 minutes after slowing down or resting. His blood pressure is 130/90, heart rate of 80, LDL is 130, HDL is 35, creatinine is 1.3. Does not smoke, no family history. He exercises on a recumbent bike to breathlessness without chest pain, interestingly. His ECG shows normal sinus rhythm, borderline Q and lead 3. Next best step in this patient, ETT MPI, Alexa scan MPI, or CTA, or cath. This patient's got some similarities to the last patient, but the difference is he's younger. He has no prior coronary disease history. his pretest probability is relatively low despite the typicalness of his symptoms. So in this patient, I think I would pick CCTA, and that's, I guess, what I picked. So it's good to see that I'm consistent. Yeah, CCTA would be a great choice for this patient. One of the things I want to say about CCTA is it's kind of an up and coming testing strategy. It's not been widely adopted yet, I don't think, in most systems, but it's getting more adopted. And some of that's based on this study, the PROMISE study, which looked at 10,000 patients who were symptomatic and had some intermediate risk of stable ischemic heart disease, and randomized them to either CCTA or functional testing. And most of those patients got some sort of imaging with their functional testing. And the primary endpoints that were measured at the end of the study were death, MI, ACS, or procedural complication. And you can see that in the table on the left, the differences in the strategies. CCTA led to a little more catheterization, probably because it can be a little less specific when there's a lot of calcium in the arteries. Therefore led to probably a little bit more revascularization, a few percent more. Total radiation dose, interesting, which is important, is about the same, a little higher if you look at CCTA, but not, I don't know, clinically significantly higher. Total radiation in the MPI group, if you're just using MPI as your functional testing, was actually higher than CCTA. So that's something to remember. Whereas if you're going to actually be able to use something without radiation for your functional imaging like DSE, then then CCTA obviously is much higher. So actually compared to MPIs, CCTA gives you less radiation. And here you can see the outcomes are flat even in terms of the primary outcome. What's interesting is there was a little hint, and it's a I don't know if it's post hoc analysis or not, but it's barely borderline significant, but little hint, less death MI in the CCTA group. Overall, if you go death MI, ACS, procedural complication is the same, so we'll consider the outcomes the same. But a little less hint of MI, and I think that was interesting because it was also supported by the Scott Hart trial, which made a lot of waves. 4,000 patients with chest pain who were all evaluated by ETT. None of them had a history of CAD in the past, so that's important. This is a good group of patients to use CCTA on them, and half were sent to get just the ETT and then whatever standard of care the clinician determined, and the other half were sent to get CCTA plus the standard of care. And that CCTA didn't change much in terms of heart caths or revascularizations, but it did result in a lot more patients being diagnosed with coronary disease, probably, maybe, non-obstructive or something like that. I'm not sure, but basically a lot more patients in the CCTA group got medical therapy for coronary disease. And subsequently, when they looked at outcomes, the CCTA group again had a bit less MI. Here you can see those in the columns in the graphs on the right. So again, CCTA may have advantages in avoiding the problem of balanced ischemia with MPIs, and B, diagnosing coronary disease, which can, if not be treated immediately with revascularization and or be immediately responsible for the patient's symptoms, can result in a secondary prevention strategy, which can reduce MI risk. So I think CCTA is a good thing to think about more than we have been. Let's get on to optimal medical therapy or medical therapy. It's a big subject. It's growing all the time. Here's a case to start us out with. A 76-year-old male. He has coronary disease. He's got a CABG, diabetes. He's mostly limited by knee arthritis. LV function's normal. Blood pressure is 138/82, heart rate of 58, LDL of 80, HDL of 35, triglycerides of 305, hemoglobin A1C of 7.8. He's on aspirin, pravastatin 40, amlodipine 5, hydrochlorothiazide 12.5, metformin 500 BID. He had myalgias, previously with higher pravastatin doses. So the next best step, add low-dose metoprolol and start alirocumab. Add lisinopril and switch pravastatin to atorvastatin. Add omega-3 fatty acids. Increase amlodipine and add ezetimibe. Or add clopidogrel and order an MPI. Well, let's think about that as we go through our medical therapy options. Here's the menu. And top of the menu are the Fab Four, I guess I'll call them. One short of the Fab Five. But anyway, here, aspirin, statins, ACE inhibitors, and beta blockers. Almost all patients should be on these 4 drugs. Aspirin, statins for sure, and ACE inhibitors and beta blockers in most patients. You can see ACE inhibitors and almost anybody with hypertension and coronary disease, as well as all those other conditions listed, beta blockers, and those who are post-MI or have LV dysfunction. These drugs have been shown in multiple randomized controlled trials to reduce risk, each of them individually. And observational trials like this one suggest they may work synergistically and have pretty powerful effects. This is observation of the 1,800 multi-vessel disease patients in the Syntex trial, all of whom were treated with CABG or PCI. Only about half of them got put on all 4 classes of drugs. When they compared those who were on all 4 classes of drugs to those who were not quite on all 4 classes of drugs, and this was not randomized, they were, this is just how the docs cared for the patients, there was nearly a 70% risk reduction in the patients who were on all 4 classes of drugs. And we've seen this in other observational studies that patients who get on the 4 basic medications to prevent events do much better than, a lot better than patients who don't. And I think it's important to think in terms of getting people on optimal medical therapy, i.e. these 4 classes of drugs. It's the second thing to remember when treating patients is that you want to achieve their goals, their lipid goals and their blood pressure goals. It's important to remember that SPRINT showed us pretty solidly that a lower blood pressure goal than 140 is better. And you can see here that they randomized patients to trying to get them to systolics of 120 versus systolics of 140. And you can see that the primary outcome, including all-cause death, was reduced with the lower blood pressure group. So I think getting the blood pressures down to less than 130 is very important. When it comes to lipid guidelines, you want to not only get people on a statin, as I mentioned earlier, but get them on a high-dose, high-potency statin. That's a minimum of atorvastatin 40 or rosuvastatin 20. And that's firstly. And then secondly, you want to get them to goal. The guidelines in the US said that they think patients with quote unquote low risk CAD, maybe single vessel disease, they should have an LDL reduction of at least 50%, whereas patients with high risk CAD should have an LDL goal of less than 70. High risk being patients who've had multiple ACS events, have PAD. You can see the list here of types of patients with multi-vessel disease, et cetera. Most of our patients, frankly. The thing I will say about that ties into the availability of 2 relatively newer drugs, ezetimibe and PCSK9 inhibitors. Those are both available, if not widely. Ezetimibe certainly is widely available. PCSK9 inhibitors are not. And this ties into the question of how low should we really be going? It's less than 70, as low as we should go. And the bottom line is we've never found a floor in terms of any of our studies in terms of lowering LDL and not getting any more benefit. Here's a here's a meta-analysis of studies which looked at patients with already relatively low LDLs and tried to lower them further. And you see in this meta-analysis that includes the cholesterol trialists study, as well as Improve It, Fourier, Reveal. And each of these studies had the patients originally enrolled had fairly low baseline LDLs, a mean of 63 milligrams per deciliter. And in these studies as a whole, they lowered that mean of 63 down to 21, and there was still a 21% relative risk reduction, going from a very low, from a low LDL to a very low LDL. So, there was no, as seen in the figure or the figure on the right, there's no increased risk of serious adverse events, myopathy, elevated LFTs, new onset diabetes, etc. So there's really nothing to lose for the most part in these, by lowering patients' LDLs lower. And the American guidelines haven't taken it in, but the European guidelines and the American endocrinologist guidelines have said that higher risk patients in particular should have lower LDLs. The European guidelines say that high risk coronary disease patients should have LDLs less than 55, and go so far as to even identify an extreme risk group of patients who have progressive CVD, who should have LDLs less than 40 milligrams per deciliter. The American Endocrinologist Society also says less than 55 milligrams per deciliter. So I would say that remember that, and we have really good available option in Zetia. It's very, well, it should be getting very cheap now. It's generic. The Improve It trial showed that lowering LDLs from 70 to 54 resulted in a 6%, not huge, but 6% relative risk reduction, 2% absolute risk reduction. So not bad, considering the drug is going to be cheap, if not already cheap, and it really has no additional side effects. I mean, there was no additional side effects identified at all in the Improve It study. This is a great add-on drug for anybody who's not meeting their 70 milligrams per deciliter goal, or who you just want to go down even lower to prevent more events. The PCSK9 inhibitors are even more powerful than ezetimibe. The Fourier trial lowered average LDLs from 90 to 30. Again, a nice reduction in MACE. This drug, of course, is a little harder to come by. It's more expensive. I think it's still about $5,000 a year. And, it's getting cheaper all the time. But I think if, it's not easy to get for that reason. I would say that, the most of the absolute benefit comes in the patients with more coronary disease, as you see in this subgroup analysis of the Fourier study. The multi-vessel disease patients have a much bigger absolute benefit than the single vessel disease patients. So if you're going to put work and effort into getting your patients onto a PCSK9 inhibitor, but you can't do it for all of them because it's tough, pick the guys with the most disease to focus your efforts. The American guidelines for lipid lowering do say to use ezetimibe or PCSK9 inhibitors as needed. So it's all of this recommendations are consistent with the guidelines in the US. What about omega-3 fatty acids? I alluded to those earlier in one of the questions. I think, omega-3 fatty acids, there's not a lot of benefit in patients who, in terms of patients taking the over-the-counter or natural omega-3 fatty acids. This has been shown, I think, in multiple trials where we're not seeing any big drop in MACE from taking combo EPA DHA. But the Reduce It trial came out, I don't know, about 2 years ago, and it used a purified pharmaceutical type of EPA called icosapent-ethyl, and it randomized patients who had coronary disease, who were on statins, but still had a little bit elevated triglycerides, anywhere between 150 milligrams per deciliter to 500 milligrams per deciliter, and randomized them to 4 grams of icosapent-ethyl or placebo. Also, this is also a drug that's also known as Vascepa. And there was a remarkable reduction in risk in MACE, CV death, MI, stroke, revascularization, unstable angina, and each of the individual endpoints were solidly reduced, including, I mean, it's borderline significant, but almost significant death from any cause. So this was a very powerful study to suggest that at least a variety of omega-3 fatty acid, the EPA version of the pharmacological version of EPA Vascepa, it may be a great add-on. And in patients, 80 patients in a different study who were randomized to Vascepa or placebo and followed by CCTA, a mechanism showed up. Basically, the patients on Vascepa had less plaque progression by CCTA at 18 months compared to the patients who were on placebo. So there's a lot of reasons to be optimistic about this drug as an add-on for patients who still have elevated triglycerides despite optimal statin dosing. What about, let's switch from lipid lowering to anti-thrombotics. I already talked about aspirin. Pretty much everybody's going to be on that. That's like built into our culture these days. But we do have a lot of other anti-thrombotic options, P2Y12 receptor inhibitors, and more recently, low-dose rivaroxaban. What should we be doing with these in chronic coronary disease patients? I just want to remind everybody about a trial that was many years old now, the CAPRI trial, and remind everybody that the other P2Y12 inhibitors, like Clopidogrel, are probably better than aspirin in terms of reducing risk and minimizing bleeding. The CAPRI trial randomized almost 20,000 patients who had prior MI, CVA, or symptomatic PAD to either get Clopidogrel or aspirin, followed them for almost 2 years. And it wasn't big, but there was a 8.5% relative risk reduction in the patients who got Clopidogrel in terms of MACE, cardiovascular death, MI, or CVA. There's also less severe GI bleeding in the Clopidogrel group. So less MACE, less bleeding. Back then, Clopidogrel was not generic. It was at least cost at least $90 a month, whereas aspirin was literally pennies. So Clopidogrel never took off or replaced aspirin as the go-to anti-platelet agent for our atherosclerotic disease patients. But it's a lot different landscape now. Clopidogrel is very cheap, and we also have some even more potent P2Y12 inhibitors, which are better than Clopidogrel. We know that. They reduce MACE better. They may increase bleeding a little bit, but they reduce MACE better. That are potential drugs to replace aspirin at least in our aspirin intolerant patients. The other thing I want to mention about the P2Y12 inhibitors, particularly, is in the situation of DATT. The other option we have is to add on P2Y12 inhibitors in our chronic coronary disease patients to their already ongoing aspirin therapy. And a lot of trials have done and have looked at this concept. Here's a meta-analysis of those trials in terms of DAPT versus single antiplatelet therapy in stable coronary disease patients in a relatively higher risk group of coronary disease patients, namely those with prior MI. You can see here that if you look at the trials as a whole, that the risk of MACE was reduced by dual antiplatelet therapy by about 1%. Major bleeding, unfortunately, also went up by 0.8, almost 1%. And while there was a little bit reduction in cardiovascular death, there was no real change in non-cardiovascular death and no real change in death overall. So as you can see, DAPT, you get less ischemic events, you get a little more bleeding, not a lot of change in overall mortality. So it's not compelling to add this to all of our cardiovascular disease patients, but it may be something to think about in our highest risk a risk or highest atherosclerotic burden patients who also have a particularly low bleeding risk. The other drug to think about these days was one put forth by the drug company that makes Revasc, and they studied it in the COMPASS trial, which was a trial of patients with stable atherosclerotic disease, either coronary or peripheral vascular disease, 27,000 patients. And they randomized them to 3 groups: aspirin alone, Revasc alone at a low dose of 5 milligrams BID, or Revasc plus aspirin at a very low dose of 2.5 milligrams BID plus aspirin 100 milligrams a day. And here you can see that, as one might imagine, more anti-thrombotics results in less ischemic events, i.e. the Revasc 2.5 milligrams plus aspirin 100 milligrams a day had less ischemic events, almost 1.5% less than the aspirin alone group. Interestingly, in this particular situation, unlike dual antiplatelet therapy, there was a reduction in all-cause death. Not huge, but statistically significant. Again, with the resultant reduction in ischemic events, there is usually an increase in bleeding. But in this particular situation, the increase in bleeding was outweighed by the reduction in ischemic events, and there was a net negative 1.2% chance of ischemic events or bleeding in the patients receiving the low-dose Revasc plus aspirin. So it's a tough one. Where do we put this drug? I think in our culture today, and by the guidelines, most patients with stable ischemic heart disease should be on aspirin or perhaps a P2Y12 inhibitor instead of aspirin. Patients with very high-risk stable ischemic heart disease who have a high bleeding risk, again, aspirin or a P2Y12 inhibitor is probably the best option. But if they have high-risk stable ischemic heart disease and they have a low bleeding risk, then I think the dual antithrombotic strategy should be considered. This is going to be a minority of patients. We're looking at patients who have several high-risk features of stable ischemic heart disease. I've listed some here: prior MI, multi-vessel disease, or multi-vessel stents, or multi-vessel CABG, older age, maybe they have diabetes or end-stage renal disease. But if they have several of those factors and a very low bleeding risk, as indicated by the fact that they're younger, have no history of GI bleed, no history of CVA, no anemia, dual antiplatelet therapy or low-dose Revasc plus aspirin may be indicated. By the way, dual antiplatelet therapy includes Clopidogrel, ticagrelor, but I don't think prasugrel at this point, which has not been studied in this situation. I wanted to mention we do have, I don't know, maybe up to a third of our coronary disease patients having atrial fibrillation, maybe not that many. And the question is, do we treat them with aspirin and, higher dose DOAC or Coumadin for their atrial fibrillation? I think the answer is no. For most of these patients, the FIRE trial is a trial which one of several studies that looked at this question: Revasc versus Revasc plus aspirin in patients with AFib and coronary disease. There was an increased mortality in the patients on Revasc plus aspirin, as well as an increased bleeding. I think we've had some observational studies which suggested the same thing. So most patients who have stable coronary disease that's not particularly high risk stable coronary disease, but regular risk or low risk stable coronary disease probably should just be on their Revasc or their DOAC by itself for the most part. And I think that's consistent with the guidelines. Let's jump to another category of drugs which have been shown to help reduce death and MI in patients with stable ischemic heart disease. Namely, now we have these hypoglycemic drugs, which have been shown to reduce death or MI in stable ischemic heart disease patients. Metformin was the go-to up until recently. It was never shown in a randomized controlled trial to reduce death or MI better than any other sort of better than any sort of other diabetes control agent, but rather it had a better relative benefit, i.e. a 39% risk reduction than sulfonylurea, which only had a 15% risk reduction in the UK PDS trial, which was a trial comparing diet versus pharmacological treatment of diabetes. So because of that, metformin was thought to be, oh yeah, this is going to be our good drug it has special effects in patients with diabetes. And so a lot of patients with stable ischemic heart disease are being treated with metformin, and probably rightfully so from this powerful observation. But we do have two classes of drugs now which have been approved by the FDA for not only treating diabetes, but also reducing cardiovascular events in patients with diabetes. And that is the SGLT2 inhibitors, specifically Jardiance, and the GLP-1 agonist, Victoza. Both of those have been shown to reduce cardiovascular mortality and even all-cause mortality in patients with diabetes as compared to placebo. So I think, these have been FDA approved, as I mentioned, for reducing cardiovascular events. And I don't particularly myself get into the business of prescribing these drugs, since it can be a complicated notion or issue in our diabetics. But I do push for our endocrinologists using these drugs, and I think they frequently do. And if they know their patients have coronary artery disease. Finally, I want to mention a drug that's made the headlines lately in the last few years, actually, colchicine. It's part of the anti-inflammatory drugs that have been studied recently in the last 5 years to prevent atherosclerosis progression. Colchicine has now 2 blinded randomized controlled trials supporting its use in the prevention of events in stable ischemic coronary artery disease patients. And one is the Colchicine trial, published 2 years ago in 4,700 post-MI patients. These patients were actually more ACS or subacute ACS, subacute CS. But these patients were randomized to this low dose of colchicine versus placebo. And you can see here, there's a reduction in major adverse cardiovascular events. This was mostly driven by less stroke and less urgent revascularization. There was a bit of discontinuation of this drug, as there are many drugs, about 18%, mostly due to diarrhea. LODO-CO2 was published, I think, a week or 2 ago in the New England Journal, which randomized 5,500 stable coronary disease patients. And these patients who got colchicine also had a reduced MACE event rate, this time driven by reduced MI and reduced revascularization, and less so stroke. So interestingly, there was a slight increase in non-cardiovascular death with no effect on death overall. In this study too, there was a 25.9% discontinuation rate, again, mostly due to diarrhea. So, where does colchicine stand? I mean, it has 2 good randomized trials supporting the concept that it prevents major ischemic events, probably due to its anti-inflammatory effects. It's a tubulin or a microtubule inhibitor, which impairs leukocyte response. But it's tough when you have these drugs which reduce MACE but don't reduce overall death rates. And the whole concept of adding another drug to patients where you're not confident it's going to make an overall big picture difference in patients who are already taking a lot of medications, it's tough. So I think the fact that it hasn't been shown to reduce all-cause death yet, and it hasn't been shown to, and it has a high discontinuation rate, means it's not quite ready for prime time for all of our patients with a stable ischemic heart disease. But I think we need a little bit more information. Does it work better in the inflamed patients who have high CRPs, et cetera? But it's something there that we should all be thinking about, perhaps in our patients who are having increased or repeated events despite otherwise good medical therapy, or maybe they have concomitant gout. It certainly helps with that. But it's there, and it's something to think about for sure. What about medical therapy for angina? You know, medical therapy for angina also works. All that medical therapy I was talking about before obviously was about reducing the risk of dying, which is, you know, the first thing a patient's mind is like, oh my God, I have angina, I have a blockage in my artery. You know, what can I do to like stick around in this world a little longer? But the other thing is patients want to feel better. And, you know, medical therapy actually also works for angina. We have 5 anti-anginals now. Beta blockers, calcium channel blockers, nitrates, ranolazine. And I have a bradine. I hope I pronounced that correctly. Basically, the top 3 were used in the COURAGE trial, and you see patients in the medical therapy arm did have a reduction in their levels of angina over 3 years, just getting treated with these anti-anginals. So I just want you to remind you that we can use medical therapy not only to reduce risk, but effectively to reduce angina. So let's go to this 76-year-old man. We've talked a lot about a medical therapy. I think we can rehash this question. 76-year-old man, blood pressure is a bit high by today's standard, 138/82, heart rate of 58, LDL of 80, a bit high. Triglycerides of 305, hemoglobin A1C of 7.8, not perfectly risk factor managed, is he? He's on aspirin, pravastatin 40, amlodipine 5, hydrochlorothiazide 12.5, metformin 500 BID. He's had myalgias previously with higher pravastatin doses. He does not have much angina. It says occasional angina above. So what's the next best step? Is it to add low-dose metoprolol and start Evolocumab? Add lisinopril and switch pravastatin to atorvastatin, add omega-3 fatty acids or Vascepa, increase amlodipine and add ezetimibe, or add Clopidogrel and order an MPI. If anybody wants to chime in before I switch. All right, well, I picked add lisinopril and switch pravastatin to atorvastatin. It's going back to those 4 core drugs, ACE inhibitors, aspirin, statins, and beta blockers, and trying to get with the guidelines where they're emphasized the strongest, getting people on high potency, high dose statins. And I think, you know, that's probably the next best answer. I think a lot of these answers would be reasonable, but probably the next best answer is to get him on atorvastatin and add an ACE inhibitor. I'm going to briefly pause here. Does anybody have any questions about medical therapy? Sounds like no. Okay, let's keep going. In the interest of time, I'm going to skip this one. I'm going to talk a little bit about revascularization. Who needs revascularization with stable ischemic heart disease? Well, just by way of history, you should know that revascularization was shown to be effective in reducing cardiovascular risk, i.e. risk of major adverse ischemic events, death, MI, et cetera. In the early 70s, after CABG had been invented or developed in the 60s, in the 70s, they did some CABG versus medical therapy trials, and they showed in patients who received CABG, there was less risk of death than in patients who just received medicines. Of course, if you wait long enough, all curves eventually come together, but the bottom line is the CABG patients did better longer than the medical therapy patients alone. The limitations of these studies were that there was actually no or hardly any medical treatment back then compared to what we have today. 20% of the patients were on aspirin. Statins, ACE inhibitors hadn't really been invented yet, or at least they hadn't been widely used. The other thing is there was a 40% crossover in this study. I mean, so that really dilutes the potential benefit you can see from revascularization. In favor of the concept that CABG also wasn't optimized, LEMA was not used in these patients. So basically, these are old studies. It shows the concept of revascularization is good, but it doesn't necessarily point to the magnitude of benefit that we see in our contemporary era. I want to point out also the subgroups of patients that were shown to benefit in the CABG versus medical therapy studies. Three vessel disease in particular was shown to benefit, as well as left main disease. I also want to point out that look at the medical therapy risk of three vessel disease versus left main disease. Three vessel disease, 17% risk of mortality, but left main disease even worse, 36% risk of mortality. And look at the relative benefit that CABG incurred, about a 30% or maybe a 40% risk reduction in the three vessel disease patients, but even a 60 to 70% risk reduction in the left main disease patients. So left main disease patients sticks out as a separate category above and beyond by itself. Also, patients with abnormal LV function tended to benefit the most. Patients with a lot more angina tended to benefit more. Patients with LAD disease tend to benefit more. So basically, I just wanted to remark on those groups because those are the groups that we, to this day, think benefit the most from CABG. So what about revascularization in contemporary medical therapy era? The contemporary medical therapy era started around 2000 or so, when where the guidelines and when there was availability of the medical therapy that we have now, and the guidelines started to emphasize their use. We have three studies that came before the highly touted ischemia study released last year. Three studies that looked at revascularization in the contemporary medical era. And it's COURAGE, Berry 2D, and FAME2. All of these studies took patients who had been identified to have epicardial coronary disease after invasive coronary angiography and randomized them to revascularization versus medical therapy alone. All of them got medical therapy, but it was revascularization versus no revascularization. Berry 2D included PCI and CABG, whereas COURAGE just focused on patients who would be best served with PCI. And basically here you see the results. All three of them showed no real benefit in terms of reducing major adverse cardiovascular events, specifically death or MI, by adding revascularization to medical therapy. There were limitations. Basically, the patients who were selected for these studies tended to have mild, in some cases even no ischemia was demonstrated before their randomization. All these patients were randomized after angiography, suggesting there could even be a selection bias on anatomy, with the patients with the worst anatomy not being enrolled in the studies. And finally, there was really minimal use of second generation drug-eluting stents and FFR. That was used in the small FAME2 study, which had about 800 patients, but not in the bigger COURAGE and Berry 2 studies, each of which had 2,500 patients. So the bottom line is there was limitations in these studies, and out of these limitations arose the ISCHEMIA trial, which tried to address these limitations because the COURAGE, FAME2, and Berry 2D trial were not well embraced by the cardiovascular community. And it was felt that a bigger, more powerful study that addressed the limitations of those studies would need to be done. And so ISCHEMIA trial was created, and I listed some of the eligibility criteria here that are important. Basically, they mandated that patients have at least moderate or severe ischemia. None of this mild or no ischemia business. At least a 10% MPI defect. They also excluded patients who had a lot of angina to reduce crossover, because crossover in those other studies was very high, above 30%. And you basically, if a lot of patients cross over, you can't really see the benefit of revascularization. So they eliminated class 3 or 4 angina patients. They also eliminated patients with low EF. Those have never been studied in any of these revascularization studies. And they eliminated patients who had left main disease or non-obstructive disease by getting a blinded CCTA. All the patients before their randomization got a blinded CCTA. So they're all, I want to go back one slide. All these patients were randomized before invasive coronary angiography, unlike the other 3 trials. So there'd be no selection bias. People with like 90% Prox-LADs wouldn't get funneled out of the study. Instead, they allowed those people in by randomizing before coronary angiography, but they did get a CCTA, which on most of the patients, and if the patients had left main disease or non-obstructive disease, they were taken out of the study. But otherwise, nobody knew the results of the CCTA. Here you see that 8,500 patients were enrolled. They all had some degree of angina, or they were either asymptomatic or had up to CCS2 angina, and they had at least moderate ischemia. Now, when they did the CCTA, they eliminated about 20% of the patients based on the fact that they had no obstructive heart disease. So these patients either had false positives, MPIs, or they had microvascular dysfunction, and that's pretty consistent with most of our data showing the sensitivity and specificity of MPIs. They also picked out about 7% of the population who had suspected left main disease. Many of these patients didn't have left main. The CCTA leaned a little bit towards overcalling it, but the bottom line is they took out those patients. The rest of the 5,179 patients were randomized, with one group getting just intensive medical therapy based on all those drugs or most of those drugs that I just mentioned, and the other group getting the intensive medical therapy with cath and revascularization, focusing heavily on FFR if patients had less than 80% stenoses, and aiming for full revascularization in any vessel greater than 2.25 millimeters. And you can see here by CCTA that the patients did have a lot of coronary disease. 77% of them had 2 or 3 vessel coronary disease. Half of them had 3 vessel coronary disease. Half of them had Prox-LAD disease. So this was a group of patients that anatomically was burdened, as well as had a lot of ischemia on their functional tests. Here you see what happened to them. About almost all of the patients, 96% of the patients who were assigned to the revascularization group got cath, and that resulted not in everybody getting revascularization, but about 80% of the population in the invasive group got revascularized. Those who didn't, a lot of them did not have, still did not have significant vascular disease, and some of them were unrevascularizable because they just had diffuse disease. That's pretty standard for us cathing people with stable coronary disease. On the other hand, the conservative group, they didn't have a huge amount of crossover. You can see here that only about, in the end, 23% of them crossed over to invasive therapy. Most of these crossovers were due to events occurring in the patient, i.e. the patient had an MI, and so they went to get a cath afterwards. So there wasn't a lot of crossover just due to angina or the doc or the patient feeling like they needed to get invasive therapy. Here you see the results. The primary outcome of cardiovascular death, MI, hospitalization for unstable angina or heart failure or recessive cardiac arrest was statistically no different in the 2 groups, although there was an early increased risk in the invasively treated patients and a later slightly increased risk in the conservative treated patients. This is called the crossing of the curves, and that did cause a lot of consternation. What was this due to? Well, it wasn't due to all-cause death. There was absolutely no difference. The curves are completely superimposable at 6.45% in the invasive conservative arm. It was due to myocardial infarction. There was an early risk of myocardial infarction in the invasive therapy group and a later risk of myocardial infarction in the conservative therapy group. And if you look at what this is all about, it's more procedural MIs in the invasive therapy group and more spontaneous MIs in the conservative therapy group. When they looked at all the different subgroups in the study, patients with lots of coronary disease, i.e. 3-vessel disease, patients with prox-LED disease, patients with severe ischemia, none of the patients seemed to benefit as a whole from revascularization compared to medical therapy alone in terms of reduction of major adverse cardiovascular events. And they did a whole bunch of subgroup analysis, and basically there was no real benefit to, no real heterogeneity in any of these subgroups of patients from the main trial results. What they did see was that the revascularization treated patients did have a bit better improvement in outcome, in quality of life. Both of the groups improved their quality of life, but the invasively treated patients had a bigger improvement. And that was due to the patients who were symptomatic. A good portion of these patients in this trial were not symptomatic, but the patients who did have symptoms seemed to have a substantially increased quality of life when they got invasive therapy compared to the patients who were just treated medically. Here you see the asymptomatic patients really no benefit in terms of quality of life. So what were the conclusions of this study and maybe of all the contemporary revascularization versus no revascularization studies? Well, first of all, non-invasive management of stable ischemic heart disease seems to be safe. There's no increased risk of, dawdling or sitting on a patient in the clinic who has a big defect on nuclear. Matter of fact, there's a little increased risk of early on of sending them to the invasive route if you look at the ischemia results. So anyway, so non-invasive therapy is safe. I think defining coronary anatomy is still very important. None of these studies have, including ischemia, have ignored coronary anatomy. First of all, 20% of patients with big defects in some form of angina do not have coronary disease, or at least not epicardial coronary disease. And it's good to diagnose that. It changes everything. Or it changes a lot of things. It's also good to exclude left main disease. I showed you those earlier subgroup analysis of the CABG versus medical therapy groups. CABG patients have a much higher risk than even 3-vessel disease patients and a much greater benefit from revascularization. And I think it's important to select those patients out and treat them probably still with revascularization. I mean, the jury's out on that, but I don't think we should ignore that these patients may do better with revascularization. And finally, risk stratification, and I didn't show you the data here, but risk stratification of patients just in general of knowing what events they're going to have, or if they're going to have an event in the future, is much better using anatomy than ischemia as diagnosed by microcard perfusion imaging. The other conclusion I want to say is that initial invasive management of stable ischemic heart disease does improve the quality of life in the patients who have angina. Asymptomatic patients is not going to do much for them, but patients who have angina, it does improve quality of life, particularly if they have more angina. I mean, once a week or more of angina. Once a month, I'm not sure how much it makes a difference. Finally, initial invasive management does reduce spontaneous MIs in exchange for more procedural MIs with no difference in mortality, at least not out to 4 years, which is the outcome follow-up of the ISCHEMIA trial. Will longer follow-up show that the increased spontaneous MIs in the invasively treated patient and the conservatively treated patients may result in a mortality difference? I think we need to do longer-term follow-up, and that's in process. But I also will say it's probably not going to make a difference just statistically. I wouldn't bet on it in terms of all-cause death when you see how tightly those curves were wound. But we do need to know, and we also need to know what the difference in these MIs were. Who had the larger MIs, the procedural guys or the spontaneous guys? We just really don't know enough about the MIs, and I think we need to find that out. What are the implications? Well, I think the implications are that in stable ischemic heart disease, patients with normal EF and not particularly frequent angina, class 2 or less, a short course of medical therapy while the patient is informed about the invasive versus medical approaches and has given a little bit of time to consider the options as well as to see where medical therapy takes him or her in terms of symptoms is the best approach prior to taking somebody to the cath lab. I think initial invasive therapy may be preferred by many, if not most of our patients who have angina and are very functional and have, good long-term non-cardiac prognoses. We don't have great long-term data on the non-invasive strategies. So, if they want to feel better and not take any chances that this spontaneous MI difference is going to cause a problem for them in their more distant future, then I think a trip to the cath lab is fine. Initial conservative strategy may be preferred in the asymptomatic patients who otherwise feel well, and also in those who have poor non-cardiac prognosis. If their time horizons are not very long, are octogenarians, they got a lot of comorbidities, medical management may be the way to go, even if they have a 25% defect. I think I'm running out of time here. I would love to go on, but I'm going to respect your time. And I will, I'll just leave this question alone for you guys to look at. I'll be able to happily entertain any questions you all have too.
Quick 2 questions if you have time.
Sure.
How did ischemia define procedural MI?
So that's a great question. So spontaneous MI was any elevation in troponin and symptoms. So if you came in, you had a little chest pain, and your troponin was 0.04 at the VA, for example, you had an MI. That was spontaneous MI. In the main definition that you just saw in the ischemia trial results for procedural MI, the cutoff of enzymes was much higher. It was, I forgot what it is, I can go back, but it was like at least a 20-fold increase in, I can't remember what it is, 20-fold increase in troponins, as well as symptoms, and if possible EKG, as well as symptoms and EKG changes. So the threshold for procedural MI as used in ischemia was much greater in terms of the amount of myocardium that had to die than in the spontaneous MI threshold or the spontaneous MI definition. There's a lot of controversy about what definition to use. And if you want to, the definition closest that resembles ischemia's definition, it's not exactly this, but it's the SCI definition of MI. So the Interventionalist Society's definition of MI, which is, a conservative definition. Let me put it that way.
Thank you.
You're welcome. Yeah, I think that MI analysis is going to be very important. It could be that we're, the type of MIs we're diagnosing now compared to 20 years ago with troponin is much different, right? We're diagnosing anybody with a little bit of a few cells, I'll say, of myocardium dying as having an MI if they have in terms of a spontaneous MI. Actually, the thresholds for procedural MI require more myocardium to die. The flip side is, that you can imagine that spontaneous MI has the potential to kill tons of myocardium. I can say that there was no difference in ischemia in terms of what they call complicated MIs, MIs which cause shock, hemodynamic instability, a drop in EF, electrical instability. There's no difference in the complicated MI groups, but a broader analysis of the MI difference, I can't tell you. Any other questions? All right. Well, thank you so much. You can shoot me an email if you want, if you have any questions. There's more to talk about in terms of CABG versus PCI, in terms of follow-up of these patients. Maybe we'll save it for another day. Maybe at some point we'll have to divide this lecture into 2. I don't know, Kunal. But I really appreciated the chance to talk to you all, and let's go out and stomp out coronary disease. See you later, everybody.
The preceding program is copyrighted by Emory University.